Cosmetology is a science. Cosmetology is an art. Cosmetology, when I say it to be science, we have to learn it properly. Cosmetology is an art. You have to do it properly. Once we learn properly, we will do it properly. Younger generation people, what they do is when they do one case of vitiligo surgery or one case of hair transplantation, they think that they become masters. It's actually foolish. Every case is a material for us. Every case differs. You say that a man will die within 15 days, he will live for 150 years. You say that he will live for 150 years, he will die within 15 days. So no one on earth can predict. And cosmetology is like that. It's growing. The main aspect here is don't promise too much. Don't expect too much. When you end up with complication, how to face. When I say don't promise too much, 70% of skin diseases are not curable. Only 30% are curable. Out of that 70%, 50% can be controlled with our cosmetic procedures. So our remaining 35% is left out. Only God can help. So don't promise too much. This is the first thing. Second one, don't expect too much. You should not think that just because we are a cosmetologist, we can cure everything. Beyond our reach, there are lots and lots of things. For example, a case of vitiligo. We think that it is stable. It should have not increased beyond for 2 years, nearly it's stable. But after going in for a surgery, it may start spreading. So no one on earth can predict things. Tell the patient that we will try to help him. We will help him. Don't promise too much. Third one, when you end up with a complication only, your real knowledge comes out. So, not like Abhimanyu, first learn the art, read the art, become an expert in the art, and see that if at all you end up with complication, come out safely. Because in my practice, I have seen 2 legal issues. One, skin graft on the lips. Another, Botox producing a facial injury in the face. Even after 17 years, till now I am afraid of each and every surgery. What will happen? Who will improve? Who will not improve? Nobody can tell. So be guarded in your language. Tell them that you will help. Right? First we will start with the vitiligo surgeries. 4 stages. 1, punch grafting. 2, split skin grafting, which can include a suction blister grafting also. 3, 5FU needling. 4, melanocyte cell culture. So these are the 4 modalities by which we can cure 50% of the vitiligo, which is not being cured by dermatologists. Again and again I am telling, don't promise too much. So first we start with punch grafting. I am just going to do 3 grafts. Earlier we used to tell that there should be a gap between donor and recipient. Now I tell that no gap between donor and recipient. The donor should be little bit smaller in width. That will be better. If the recipient is larger, what happens is the melanocyte kelon, the inhibiting factor, is all thrown out of that area. That itself is going to be a cure. So no gap between, No difference between donor and recipient area. If the recipient is large, if at all you take a 4 mm graft of a recipient, donor if at all you take 3 mm, doesn't matter. That itself is going to be a cure. As you know, dermabrasion is a cure for vitiligo. Just needling will give a cure of vitiligo. Injecting plain saline into vitiliginous area can cure vitiligo. This is all trauma. Whenever we induce a trauma, the pigments is going to come out for a healing purpose. So, everything is going to be a treatment. The main objective is produce a trauma and graft. Now, 3 mm graft I am doing. I am just going to show you graft. I think you are able to see it. 3 mm. Only 3 grafts I am doing for a demonstration purpose. These are 3 grafts. The vitiligo, first thing is see whether it is stable. Otherwise, make it stable. How to make it stable? Stability is achieved only with steroids. Without steroids, no stability. That should be the main thing. Because our own community, dermatology community, the harsh reality is that it's like crab community. When one puts a vitiligo patient on steroid, the other doctor tells the other way. He tells that the doctor has put you on steroids, it will kill you. Without steroids, no stability in vitiligo. Right? Second one, SSG. I'm going to demonstrate it in the same patient. I'm using it just a small blade. You can use humble knife also. There is another knife called Silver's knife, which will be simpler. See how we take. It should be very thin, very thin, very thin. Skin graft. This is a very, very simple way. You can learn it in your house itself with the help of a tomato or a potato. That will be easy. With this graft, we can go in for a melanocyte culture also. Now I am going to go in for only SSG. For a melanocyte culture, the procedure is very simpler again. Melanocyte cell suspension. Take the graft, put it into a dissociation media. Put it into a dissociation media. Take it out. Add melanocyte culture suspension. Melanocyte culture suspension. Take it out. Again, wash it with dissociation media. Put it into an incubator, 37 degree for 45 minutes. Take it out of the chamber. Remove the epidermis and dermis. If at all you are not able to remove, doesn't matter. Add 2 ml of melanocyte culture media again. Grind it. Make it into a gel. And then put it into a test tube. 1200 RPM in a centrifuge for 6 minutes. Inject it into the vitiliginous area or dermabrate and just apply that. So both ways we can do. So with the graft, SSG graft, we can do both. One SSG, 2 culture. Only thing, the culture media, I will show you the culture media, the dissociation agent. This is dissociation agent. This is neutralizing agent. This is melanocyte culture media. Dissociation media, we have to mix 10 ml, 4 ml for first wash, 6 ml for second wash. Melanocyte culture media, 3 petri dishes, 1, 2, 3 ml. Neutralizing media for neutralizing after taking out of the centrifuge, after the taking out of the incubator. Blade. Yes, right. See, I think you are able to see that. I am just going to put a small patch. Skin grafting can be done only on immobile areas. Skin grafting can be done on only mobile areas. Immobile areas. Punch grafting can be done on mobile and immobile areas. Tattooing can't be done on a palm or sole. Tattooing can be done on other areas. Skin grafting only on immobile areas where we can go in for a good pressure bandage. Punch grafting will be safer option. See what I am doing. Grinding. There should be a fresh blood. The dermabrasion should go beyond the vitreogenous area. Dermabrasion should go beyond the vitreogenous area. The border should not be spared out, because you expect a rolling of your graft which will leave out a vacant vitreogenous patch later on. So, go beyond the vitreogenous area and close it. Blade. See what I am doing. Give a liberal bleed. You should have seen people who are in the tile industry. They paste the tiles on the walls by creating small wedges. Same way, create small wedges here. And onto the graft, create small wedges, so that the serum does not throw your graft out. The serum should not throw your graft out. This is the basic thing. Otherwise, it's so simple. The only thing, we have to have a good amount of bleed. The bleed should be heavy that the results will be nice. If the bleed is not good, the survival will not be good. If the graft is thick, don't worry, except for the cosmetic thing, the results will be very nice. So this is SSD. Again, a very simple procedure. We can close anything like that. Leave it for 20 minutes. See that sleeves there. That should be the main thing. Without putting a sleeve on the donor graft, don't go in for a surgery. Punches. See how I am going to do a punch? Start from the periphery. See, this is the border. Start from the border. Otherwise, it will leave out windowing. We should not leave out windowing. I'll just tell you how to go about. See, if this is going to be the vitiliginous patch, start the punch grafting like that. If it is 3 mm graft, the gap between both grafts should be 3 mm. So, start from the periphery. Don't start from the center. The periphery should be covered initially. Then, inside the gap, go in for 1, 2, 3 like that. Right? Third row should be in between both. This is how it should be done. Start from the periphery. Don't leave the periphery. Otherwise, if you are going to put a graft on a normal skin also, it's good. Don't worry. But don't leave alone the border. This is one thing. Skin graft, as I told you, if this is going to be the vitiliginous area, dermabrasion should go beyond this area. The graft should go beyond this area because we expect a rolling of the graft. The graft will definitely roll out. Expecting that it will roll out, the dermabrasion should go beyond the vitiliginous patch. That will be 100% successful. 2. 3. After finishing the SSG, split skin graft, leave 20 minutes. Don't put a dressing. After punch grafting, leave 20 minutes. Don't put a dressing. Allow the graft to settle down. Then go in for a pressure dressing. Pressure dressing for both. So 3 punches are just for a sake of teaching, I am telling you. Start from the periphery, go down to the whole patch. Third one, 5FU needling. I am a lover of 5FU, 5-fluorouracil. I am normally being called a rebel dermatologist or a rebel cosmetologist. When I started 5-fluorouracil before 8 years, I was called a fool. What is the basic pathogenesis here is, when you produce a chemical cauterization for healing purpose, skin goes in for a rejuvenation, it goes in for a reepithelialization. In the process of reepithelialization, the melanocyte also comes into the vitiliginous area. So, you produce a trauma, you produce a chemical reaction in it with 5FU. 5FU can be used in this, 5FU can be used in IGH, idiopathic guttate hypomelanosis. 5FU can be used in lichen sclerosis, a tetraficans, normally which we tell is not curable. LSA, white spot disease, we can try. In a wart we can use, in a corn we can use. So what I tell is 5FU in 5 skin conditions. Viral condition, hypertrophic skin condition, depigmentary condition, everywhere we can try 5FU. Now, after doing a punch grafting or skin grafting, on the punch grafting area, after 15 days, after removing the dressing, after finishing of the procedure, you can reapply 5FU daily at night, 5FU 1% daily at night. That will give a remarkable result. You finish off your punch grafting, apply 5FU 1% liberally on the lesion after removing the dressing. Continue for 2-3 months. You will definitely get a very good result. Because when the skin matures, when the skin heals out, when the fibroblast produces more collagen, when the melanocyte produces more melanin, when the tissue goes in for a healing, it will produce very good effect with 5FU. So without 5FU, don't ever stop punch grafting. My advice to youngsters, start punch grafting. Go with punch grafting. Future punch grafting. Because normally 90% of punch grafting we don't fail. 30% of skin grafting fails. The procedure fails. Again, we are going to be answerable to the people. So, see that which is the best one. That will be the one. Complication. If the grafts are little bit larger or it becomes little bit hypertrophic, it forms a polka dot appearance. This is the skin. The vitiligo you have implanted, it goes in for a pigmentation, but this graft, if at all, it produces polka dot appearance. What is the issue in that polka dot appearance is, if you would have placed the graft inside the recipient area, push it into the recipient area. Don't ever think that it is to be exactly similar to the skin. Don't ever think like that. This is a punch. You put the punch inside. If it is submerged, that will give good results. This is the skin. Don't ever think that you have to just match it to the skin. Don't do that. These are all practical points. Put your grafts inside. See that it gets submerged. After healing, start with 5FU topical 1%. You will be 100% successful. Polka dot appearance as a complication of vitiligo, if at all you have it, you can go in for a dermabrasion. Otherwise, you can remove it with a small punch itself. Because once it's pigmented, thing is all over. Remove the punch, remove the polka dot appearance lesion, remove it. Just apply a topical antibiotic, everything will go off. This is second one. Third one is 5FU. If you are afraid about punch grafting, if you are afraid about skin grafting, go for 5FU needling. 5FU needling, simple procedure. It can be done with a small needle or it can be done with derma pen. Now I am just going to show you both things. People say that it's not to be applied on the mucosa. Don't think that way. You see a lip vitiliginous lesion, you see a lip vitiligo. If you are not interested to go for surgery, ask the patient to apply 5FU 1% liberally daily night. If you can mix it with a steroid, the anti-inflammatory property also will help. So topical steroid, something like mometasone with 5FU 1%, mix and apply at night on the vitiliginous area. 30 to 40% will heal off nicely. The pigmentation will be very good with that. Otherwise, if it fails, you can go in for 5FU needling. The first step will be just topical 5FU. If not, you can go in for needling or derma pen. I will just show you how to needle it. See this vitiliginous area? There should be liberal blood. You can apply 5FU and needle, or see how much blood is coming out, and then go in for a nib. Derma pen. Again we can needle it out. Leave alone for 10 days. You can close it. If it becomes more painful, within a dressing, open it. Otherwise, leave it for 10 days. Definitely it will close. See, there is this amount of blood, and then liberally again apply 5FU. Don't remove the 5FU. Liberal application, just leave it out like that. Leave it for 10 days, remove it. If it is more painful, if it is very, very tender, you can remove the 5FU within the 10 days, but the results will be very nice once we get a complication of this. The complication of 5FU will be necrotizing lesion there, but everything will go off. On a lip, or any mucosa for that matter, you even cut the lip with a knife, it's going to close out properly. So don't worry. You do a punch grafting, you may think that, Acha, we have put a 6 mm graft, 7 mm graft, how is it going to heal? The results will be very, 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 very nice on a lip. Any lip vitiligo, any mucosal vitiligo responds very, very nicely. Next, we will go in for tattooing. Right. This is targeted phototherapy. I think you are able to see the wavelength of a targeted phototherapy is 308. With that we can induce pigmentation. Only thing we have whole body pua, but we can end up with complications of pua chamber also. But here this is one thing, target phototherapy can be done along with surgery, can be done along with punch grafting, can be done along with skin grafting, can be done along with 5FU. Right? The thing is, it's a spot phototherapy. So, it's of hectic use. But what I advise is, 1 lesion, 2 lesions, stable, go in for a targeted phototherapy. Otherwise, please don't go in for it. The main thing is stability, stability, stability. In a whole body pua, you can go in for even unstable vitiligo. But targeted phototherapy, only stable vitiligo. See that? I think you are able to see me. Leave alone for 1 to 1.5 minutes, otherwise 90 seconds, till there is a little amount of burning sensation. If the burning sensation is high, stop it. Next procedure will be tattooing. Tattooing, first start with the black pigment. Tattoo, we can do it on all areas except palms and soles. Palms and soles, when there is a good amount of sweating, everything will get extruded. Tattoo, first coat should be black always. Above it, you can use brown, you can use yellow, you can use white, you can use pink, anything, anything, anything. If you want to have a good result, first layer should be only a black pigment. Second pigment can be any pigment for that matter. See how I am doing. This is the chamber. See the black thing. I think you are able to see that. This tattoo machine, the speed is 40,000 RPM. When we tell it to be 40,000 RPM, the results will be good. There are smaller versions which won't be so good. This gives a very good result. This can be used in eyelining. This can be used in cosmetic tattooing and therapeutic tattooing. Cosmetic tattooing, we use single needle. Here we use multiple needles. After finishing off the tattooing, we have to use a fixer. Fixer is a small gel which contains your talc-like granules. It is ethylene oxide. Your Johnson powder, Johnson lotion, everything contains ethylene oxide. It will be a very good fixer. You apply that, at least 10% of pigments which normally thought to be extruded will get stopped. One thing, we can go in for a revolving motion, otherwise we can go in for a perpendicular thing. But what I normally advise is, one time perpendicular, the other time perpendicular to the same tattooing area. That will be the 100% curative thing. See how it goes off. Above it, we can use any pigment for that matter. See the covering now. I think you are able to see that. See the covering. Now, right, now we can use brown pigment over it to see that we match it. Brown shades, there are in and around 24 brown shades, because Indian skin is all brown. So we have to match it properly. Even if you match it properly, we won't be able to get 100% matching. So that we should tell the patient. We should not expect more. We should not promise more. Acha, what will be the complication of this tattooing? I told you, one, how to do it. See that we don't end up with complication. If at all we end up with complication, how to remove it. Sometimes this tattoo can go in for tattoo granuloma. If it forms a granuloma, how to get rid of a granuloma? One, we can go in for IL steroids. If at all there is a granuloma, again we have to go in for a second coat. One coat of black with three coats of brown. 3 coats can be yellow, 3 coats can be anything, but Indian skin, 3 coats of brown. 1 coat black, 3 coats brown. So this is how we have to go things. Above it, we have to apply that fixer. That will be of much use. The next surgery, eyebrow reconstruction. Before that, I will tell you a little about medical cosmetics. We will start with lipsticks. The most voluminous purchase in whole cosmetic industry is lipstick. Lipstick, a girl who wears a red lipstick is stared by males for 7.2 seconds. A girl who wears pink lipstick is stared by a male for 6 seconds. A girl who does not wear a lipstick is stared by a male for 2.2 seconds. Red lipstick, staring will be 7.2 seconds. Pink lipstick, the staring will be 6 seconds. No lipstick, 2 seconds. But unfortunately, a female in her whole life eats in and around 1.5 kgs of lipstick. 1.5 kgs of lipstick is eaten by every female. So what are the harmful chemicals which are present in the lipstick which we have to see? As a whole, the cosmetic industry, 1, perfumes, 2, penetration enhancers, 3, dye, coloring dyes, 4, sticky substance. You have to, if it is a lipstick, it has to stick onto the lip. If it is a hair dye, it has to stick onto the hair. So the sticky substance. These are the 4 substances which we have to see. What are the common things to be seen in a lipstick? It can contain named dyes. Named dyes. Named dyes in the sense it can be C1, C2, C3, C4, C5, C32. Named dyes have to be avoided. 1. 2, dyes containing paraben to be avoided. Dyes contain propylene glycol to be avoided. What are the harmful chemicals in all cosmetics altogether is, 1 is phthalate, 2 is paraben, 3 is propylene glycol, 4 is polymethyl methacrylate, 5 is formalin, 6 is dyes, 7 is hard minerals. Hard minerals in the sense it can be mercury, it can be lead. Even lead is added to lipstick. So, before applying a lipstick, see that you are using a safer one. 1, you use a lipstick, remove it properly. See that it is completely removed from your lip. Occasional, rare use of cosmetics, good. This is a cosmetic world. Here we can't be devoid of cosmetics, but how to use it safely. Now we are going for a reconstruction of eyebrow. See this? See this? See, I am drawing a line. It should be very thin. It should be very thin. In all surgeries, underdo, don't overdo. Underdo, don't overdo. I think I have constructed temporarily. Now we will make it permanent. It's a single needle. This is all very simple. Very, very simple surgeries. Hardly 2 minutes, 3 minutes. You can give a good result, good psychological advantage, good cosmetic acceptability. The main thing is that we should not go beyond the applicated agent. If you go beyond that, you can't remove it. So underdo, underdo, underdo. This is a permanent tattooing. See how I am creating it. It has to match it. I think you are able to see that. Right? Simpler like that. Good. Next, soaps. The whole cosmetic industry is flooded with soaps. Every company is coming after one or either soaps. How to judge a good soap? Earlier, there were 3 classifications of a soap. 1, made of plant fat, 2 made of animal fat. 1 containing photosensitive chemical, 2 does not contain photosensitive chemical. 3, a soap which has high detergents which has low detergents. High detergents, low detergents. This is the basic classification. High amount of detergents will produce wrinkling, will produce aging of skin. So, high amount of detergents should be avoided in a soap. Animal fat produces a good lather, but any soap producing a good lather is not a good soap. It's to be a good cleanser as such. The surface tension on the skin has to be reduced and all your dirt has to come out. That is the basic thing. Third one, TBS, tribromosalicylate should be less than 0.5%. Otherwise, it will get oxidized and it can produce hypopigmented skin lesion over the face. Hypopigmented skin lesion over the face commonly can be soap dermatitis. Can be due to this TBS. The contact time between the soap and the skin should be less than 90 seconds. It should not exceed 90 seconds. You apply a soap, you sing a song, go around the bathroom, you give a gap of 5 minutes, you are going to end up with complication. Because these soaps also contain paraben, soaps also contain propylene glycol, soaps contain all harmful chemicals. Any cleanser has a harmful chemical. As I told you, it's paraben and propylene glycol. How do we judge a good soap? The total fatty material, otherwise TFM. TFM more than 75% is number 1. 70 to 75% is number 2. 60 and above is number 3. Below 60, don't use it, throw it. TBS above 0.5%, throw it. Soaps, the contact time less than 90 seconds, normally we don't end up with any complications. But you apply a soap, the contact time becomes longer, immediately you go out in sun. Otherwise, you leave out for much more time than 90 seconds, we will end up with problems because this is going to penetrate into your sweat duct, into the sebum canal also. So, the soap material which is held up within these pores along with sunlight can produce soap dermatitis. Use it, wash it. Use it, wash it thoroughly, wash it properly. The soap does not produce any problem. Now, we are going to go in for hair transplantation. Punch graft, single hair graft, follicular unit graft, and artificial hair. Punch graft and follicular unit graft, the difference is very minimal. Punch graft, we use 3 mm, 4 mm punch for occipital area. Frontal area, to create a hair line, we have to go in for either single hair graft or follicular unit graft. If at all you are going to use for frontal area, single hair or follicular unit transplant. All others, we can go in for punch grafting, because punch grafting, the damage to the hair follicle is low, 1. 2, the damage to the hair follicle is low. 2, it has a rich harvest of hair follicle. Removing one by one, cutting it to one by one. When there is going to be a mechanical error, we can cut the hair root also. You just implant the hair, it's not going to grow. So, punch graft in all areas except the frontal area. Frontal area, single hair or follicular unit grafting. Now, we will start with punch. I am just going to do 3 punches, 3 follicular unit graft, and 3 single hair graft. I'll just show you how to go about. But before all these things, topical minoxidil, 10% for at least a period of 5 months. With finasteride, 2 milligram initially for 3 months, followed by 1 milligram regularly. Finasteride for 2 years, minoxidil lifelong. If the patient is not going to continue your minoxidil, if the patient is not going to continue your finasteride, it's going to be a big blunder. The basic thing in a hair transplant is, God has given 2 lungs, 2 kidneys, 2 sets of hair. One is androgen dependent, one is androgen independent. Androgen dependent hair falls off, androgen independent does not fall off. You should have seen big bald people with hair at the back but no hair in the frontal area. So we transplant the hair from the back to the front. When we transplant from the back, when we take, what we should see is, this is the donor area. The punch should go like this, or a singular, it should start from downwards, go upwards. Downwards, go upwards. When you transplant from upwards, downwards. This is the basic thing, because if you take a vertical incision here, if you don't have an inclination, you are going to cut your hair roots. You see, hair is growing like this. Hair is growing like this, and again it curls down back. Same way in the back, it's present like that. So the inclination of the hair is the main thing. Transplantation also, the inclination has to be the same thing. Otherwise, you will end up with porcupine hair. The hair will all start to stand. The whole procedure is going to fail. So these are the main things. Minor things, main things. Minor things, main things. See how we do. Punch. 3 mm. This is a 3 mm punch. We can use 1 mm punch also. If you need a follicular graft, 1 mm punch also will be helpful. The only thing, it should be something like a punch grafting. Go to the deep. Earlier we used to tell that we have to trim the fat from the punch. But don't do that, don't do that, don't do that. Because with the fat, the blood, normally the blood from the recipient area, will be very nice if at all with the fat only. So don't ever trim anything. See how I am doing. Just 3 grafts. It should be as if you are not cutting the lesion. It should be removal of the lesion. See, 1. This is a 3 mm graft. One 3 mm graft will contain in and around 6 to 7 hair roots. Then we will go in for a strip graft. It's again very simple. A larger strip of 2 inches size, 2 centimeter thickness, 2 inches size, 2 centimeter thickness will give in and around 900 hair roots. 2 inches length, 2 centimeter breadth. Now I am just going to do a small thing, since it's going to be a demonstration thing. See how I am doing it. Here too we have a silver knife. Silver knife has 2 cutting edges. This strip has to be cut into pieces. That is the thing which we have to be careful about. We have to see that we don't cut the hair roots. That's the basic problem of all the things. I have a very good team. They are very faster than me. They implant in and around 900 to 1000 hair roots. Otherwise, they harvest 900 to 1000 hair roots within a period of 40 minutes. So again, another 20 minutes, you can finish the procedure within 1 hour. But the team should be good. 2 inches length, 2 centimeter breadth will give a harvest of 900 hairs. The failure rate will be 10%. 10% failure rate is expected in any procedure for that matter. So we can tell the patient that around 800 hairs will grow. But without minoxidil, without finasteride, the hair transplanted area, the hair will grow, all others will fall off. So the patient has to be obedient to us. Cosmetology patient, if at all they are not obedient, don't ever try to do a cosmetology procedure for that patient. A patient who asks too much is not going to be a good patient. A patient who needs our help, we should help. A patient who reads the internet and comes and sits in your chamber, who kills you, leave that patient. Leave that patient to a doctor whom you don't like, because he is going to kill your life. Right? So real needy people, we should help. Some people even tell that they will go in for a suicide. They will go in for a suicide if they don't have hair. For those people we can help. Others we don't need. Follicular unit graft is 0.9 mm. We did a punch graft. Punch graft was 3 mm. This one is 0.9 mm. This can be fixed to a dermabrader or follicular unit graft. Both are same for that matter. I will tell you how to go about. The only difference between a follicular unit transplant and your dermabrader will be, there will be a counter in FUU machine. So how many hair you are transplanting will be seen there. The patient can be shown that we have transplanted 900 hairs. But other than that, it's of no big use. The gap between one graft to the other graft should be in and around 2 mm in a single hair. In a punch, the gap between one punch and the other punch should be the same size of the punch. In a motor hair transplant can be done with 3 mm, 4 mm. As I told you, 3 mm, 4 mm only for the occipital area, only for the center of the head, frontal area, single hair. Now I will show you how to go for single hair. Follicular unit transplant. 5 of you see the needle. Follicular unit. FUE. See this, it is 0.1. The seconds between one pulse wave and the other pulse wave will be 1 second. It can be modified to 2, it can be modified to 3, it can go up to 5. What I do is a continuous mode. We can be, if you want to have a faster thing, go in for a continuous mode. Now I have given a gap of 1 mm. See how it goes around. I think you are able to see it. This is follicular unit transplant. So see the punch, single hair, follicular unit. follicular unit. Punches, the bleeding will be heavy. Strip graft, the bleeding will be heavy. Follicular unit, the bleeding is very minimal. So, follicular unit transplant, it will be very easy. I told you how to go about. I will just show you. இப்படி தான் போடணும். இங்கே இருக்கு திருப்பி போடு. கேமரா வருமா? இங்கே எடுக்கணும். இதை ஒரு இப்பில் போட்டுக்கோங்க. இப்போ இது வருதா? ரைட். நவ் I will tell you how to go about with the follicular unit, because people think that it's a very big procedure. It's a very minor one. See how we go about. See how we go about. Right. See, make it faster, make it faster, make it faster. See how much I have done. Make it faster, make it faster, make it faster. Right. So we can do 1,000 punches with this within an hour. It's so simple, so simple, so simple. People think the other way. If you can buy this follicular unit, or if you buy this 0.9 mm probe, attach it to your micromotor, that will be also simple. See that this is the one, 0.9 mm. It's so simple. The bleeding will be very, very minimal and very useful also. You need not go in for a suture. You need not go in for a dressing. Nothing, because bleeding will be very, very minimal. This is so simple like that. The only thing, this follicular unit has an added advantage of counter. Otherwise, it's similar to your micromotor. We see how we transplant 3 mm. If you don't have a FUE, you have 1 mm punch also. You can do it with 1 mm punch. See the angling. We have to angle it like this. The angling should be like this. Right? The angling should be like this. Right? Angling should be like this. See the angle, see the angle, see the angle. The main thing is angle, angle, angle. Come out. See this, your follicular unit, you just wipe it out, the graft will all go. See how simple it's like that. Right. Now we will implant. This is a punch. We have done a single hair. I think you are able to see that. What will be my advice is, have a follicular unit transplant. Have a follicular unit transplant. 0.9 mm or 0.8 mm. 0.9 mm is good. Take 1,000 grafts. 10% failure. 900 grafts will definitely regrow. People think the other way, but what's my sincere advice is, instead of going for a punch, instead of going for a strip grafting, because invariably even after 2 years or 3 years people complain about pain in the nape of the neck. Even after 2 years they complain if at all we go in for a strip grafting. This is very easy. No bleeding, nothing, 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 nothing. See how it's easily done. The pressure dressing, the dressing part is the most important in any hair transplantation. After finishing off the hair transplantation, after covering the whole area, the only thing is that we have to go in for a turban dressing. Leave it for 10 days. Don't open it before that. Normally people tell that open it before 3-4 days, see for the lesion and then do it. Don't do that. Compressive dressing, any compressive dressing for sclerotherapy or any compressive dressing done for hair transplantation should be left out for 10 whole days. After that, remove it. Ask the patient not to wash for 2-3 days. Then you can wash. See how she is transplanting. My team, Dr. Aarti, Dr. Vanati, Dr. Nitya Gayatri, Dr. Gayatri, Dr. Nidya, all my special trainees, my grand team, dynamic people. So if you can combine 1 or 2 people, it's so easy. After putting the graft, we have to press it, see that it gets submerged. I told you in vitiligo, we have to submerge. Same way, in everything we have to submerge, submerge, submerge. Singular. Good. Close it with a Sofra tool. It's so simple like that. So hair transplantation is not a big one, not a big issue. Very minor thing, minor thing. Even very simpler than your vitiligo. Have a follicular unit transplant unit or a motor dermabrader with 0.9 mm punch, motor punch. Very easy, very easy, very easy. The only thing, angling of the graft. Donor from downwards to upwards, recipient from upwards to downwards. So by seeing this, people who go to their respective places should start that follicular unit transplant immediately. By 1 motor punch, 0.9 or 0.8, attach it to your dermabrader, motor dermabrader, do it. You see, this is the motor dermabrader. Here we are using a diamond burr for dermabrasion. Same thing, you put a motor punch 0.9 or 1 mm, same thing becomes a follicular unit transplant. So you buy 1 micromotor, have motor punches of hair transplantation and dermabrader punches, both will suffice. It's so simple. Next, sunscreeners. I will talk about sunscreeners. Sunscreeners, every 3 hours we have to apply. Kana enne badu karda. Enne badu kar. Artificial hair transplantation, I will tell you later. I started on sunscreeners. Sunscreeners, what is sun protective factor? sun protective factor, you go out in sun, you stand for 10 minutes, you get burns. When you go in sun, you get burns within 10 minutes. It becomes erythematous, it becomes vesicular, it becomes itchy. When you apply a sunscreener, say the sun protective factor is 15. 15 into 10 is 150 minutes. 15 into 10 minutes, the 10 minutes which we are able to bear without getting a sun sensitivity. 10 into 15 is 150 minutes. So this 15 SPF will protect you for 150 minutes. 30 SPF will protect you for 300 minutes. But when a patient needs 30 SPF, he may not even tolerate for 1 to 2 minutes. So 30 into 2-3 minutes will count to 60. 60 in 60 minutes. Within 60 minutes, we have to reapply. So what normally we tell is the sun protective factor, whether it is 15, 30, 50, 15, 30, 30, 50, to be multiplied to the amount of time which you can stand in sun without having an allergy. It can be 2 minutes, it can be 3 minutes. You use an SPF of 50, 2 minutes you are able to survive without a sun protective factor. 50 into 200 minutes, you can withstand sun with the sunscreener for 100 minutes. So that is how we calculate sun protective factor. What we normally advise is every 3 hours wash it and reapply. Morning 8 o'clock apply, 11 o'clock wash it, reapply at 11 o'clock, wash it, 2 o'clock reapply again. So sunscreener has to be continued at least 3 times per day. 8 a.m., 11 a.m., 2 p.m. So 3 times if you apply a sunscreener, it will be of use. Otherwise, it's not of any use. If you can't, if you don't, if you are not obeying the command of a doctor, you apply a sunscreener in the morning, you apply a sunscreener in the morning, you don't apply in the afternoon or evening, you are going to get burns. A sun-sensitive patient, even if he is traveling in an AC car, if he is inside an AC chamber, it doesn't mean that he does not need a sunscreener. The sun protective factor is going to protect your ultraviolet A and ultraviolet B rays and not your sunlight. So even if you are inside a room, you are inside a theater, you are inside your car, you have to apply a sunscreener. You have sun sensitivity, you should apply sunscreener. Otherwise, again you are going to end up with sun allergy. Now we are going to go for nail avulsion technique. Nail avulsion can be partial avulsion or full avulsion. Partial avulsion normally done for ingrowing toenail. But sometimes if the infection is so huge, partial nail avulsion is not also going to be helpful. The main thing to be seen in any nail avulsion in ingrowing toenail is you remove the nail, if you leave the remnant of the ingrowing toenail inside, again you will get infected. So there we have to be careful. Sunscreeners, oxybenzone, avobenzone, normally people think that they are all very safe. They are not at all safe. In our books, in Rook, every book, any dermatology book you take, avobenzone and oxybenzone normally are being told, but they are not safe. What I tell is a zinc, a barrier cream, a hat, don't go in sun, an umbrella will be the best sunscreener on earth. I have written a book on on medical cosmetics, which will reach you which will reach you once you go to your place within a month. Everybody who is present here, I think I will be able to send it within a month. Otherwise, catch hold of the neck of Raja or Iyengar. See that you get it. See that book. I have written 6 books. This is the 6th book. I will send this copy to you. Everything about cosmetics. See this. See the infected area. This is the ingrowing toenail. So very simple like that. See that you don't leave out any remnant. Phenolize, cauterize, or use TCA on the edge and on the matrix. It will turn brown in color. Immediately you have to neutralize. Neutralize with saline. Neutralize with saline. It turns brown in color. I think you were able to see that. Otherwise, I will again show you. See, trichloroacetic acid. See that. You just apply. It will turn brown in color. Immediately after that, neutralize it. So nail surgery is so simple like that. Then we go in for acne surgeries. Mascara. A man should spoil the lipstick of a girl, not the mascara of a girl. A man should spoil the lipstick of a girl, not the mascara of the girl. Mascara is one which I apply on the eye. Mascara may contain mercury. That's the basic problem with mascara. So, as you know, mercury is a hard metal. Any hard metals on a longer term will produce nephrotoxicity. So kidney problems can occur with mascara. So you apply mascara, but immediately wash it. For good occasions, for grand occasions, use, but otherwise don't use. This is mascara. Shampoos. Normally what we apply, the shampoos which we use, all contain sodium lauryl sulfate. As such, it's not bad, but if it is sodium lauryl glucosides, it will be the safest one, and it can be used as an everyday shampoo. Sodium lauryl glucoside. Go see the cover of the shampoo which you are using today. See whether it contains sodium lauryl sulfate. If it is sodium lauryl sulfate, if you can get a shampoo with sodium lauryl glucoside, it will be very nice. The contact time between a shampoo and the hair should be minimized to 60 seconds to 90 seconds. Because the chemicals present in the in the shampoo, they don't produce hair fall, but they make the hair thin. The sulfur bonds which are covering the hair sheath, the outer hair sheath, is all being broken out by your chemical assault. So the more amount of contact time between a shampoo and your hair, the hair is going to become thin, fragile, friable and fall off. The density is going to go down. You use any shampoo for that matter, wash it thoroughly, wash it immediately. Don't go around the bathroom, don't sing a song after applying these chemicals onto your head or face. Some people do apply shampoos onto the body and onto the face and onto every part of the body. Not to be done, because the surface tension of a soap, surface tension of a cleanser, the surface tension of a shampoo is all different. They all match the structure on which it is to be used upon. So please don't do that. Lots and lots of people do it. Don't do it, don't do it, don't do it. You use a detergent soap onto the head. Some people do that also, thinking that we get a remarkable improvement in the texture and remarkable cleaning nature, but don't do that. Apply a shampoo, wash it immediately, wash it thoroughly. Now, acne surgeries. Acne surgeries, there are 4 or 5 types of surgeries, but everything should be followed by subcision. Without subcision, no surgeries on face, no surgeries for acne. Because if you don't cut the fibrotic bands behind, see, this is the lesion, this is the scar, ice pick scar, the fibrotic band is here. You put your needle inside, you cut the whole fibrotic band, everything comes out. After that, go in for any surgery. It can be laser, it can be microdermabrasion, it can be dermabrasion, it can be anything for that matter. But without subcision, no surgery. Microdermabrasion in acne scars, after subcision, the results will improve up 30%. Acne scars can't be removed, can be revised. Any scar for that matter can't be removed. Scar can be revised. It can't be removed. So, with microderm, the result will be 30% improvement. With the dermabrasion, a liberal dermabrasion, a hard hit dermabrasion, the results will be 50%. The only thing, after dermabrasion, first 2 days we have to apply topical steroids and then continue with the hydroquinone for 15 days. The post-inflammatory sequelae, the post-inflammatory depigmentation will all come down. But we have to produce a very good amount of dermabrasion. People are scared of doing dermabrasion, but that is the only one which produces very good results. Microderm 30%, dermabrasion 50%. Laser, any scar with fractional CO2 or erbium YAG. Fractional CO2 or erbium YAG, the result will be 60 to 70%. So, you can't bring back nature. We are not got to bring back nature. We will help the patient. We will bring to a cosmetic acceptability. Again the promise, again the expectation. What are the complications? I will tell you.